Morning everyone. So our study is about the outcomes of the Sedeo Excimer laser system, the world's first surface ablation in upright seated position. I do not have any conflict of interest or any financial disclosures. So the purpose of the study, it was a prospective single center study of the Sedeo Excimer laser system, which is used to perform trans-PRK as well as PTK on patients in upright seated position. So patients greater than 21 years of age with stable refractive error eligible for surface ablation were recruited for the study. So spherical equivalent for myopes less than 8 diopters and hyperopes less than 4 diopters. And patients who had a combination of Barman's dystrophy and a stromal dystrophy who were indicated for trans-PTK were also included. All patients underwent detailed ophthalmological evaluation, including a corneal tomography and as well as an ASOCT, and informed consent was obtained from all patients. So the procedure included a transepithelial surface ablation in upright seated position at the Sedeo system, which was followed by application of mitomycin C and BCL. Post-operative care included antibiotic, topical steroids and lubricant eye drops, which were tapered over 1 month. Follow-up was on day 1, day 7, 1 month, 3 months and 6 months post-operatively. The percentage of treated eyes within the target refraction of plus or minus 0.5 diopters of target refraction was calculated. So this is the Sedeo machine where you can see it's the revolutionary first laser machine which is leading the beam right to the eye via the robotic applicator in sitting position. On the right, what you can see is this is a Excimer laser box, and this is a robotic applicator as well as a slit lamp delivery system, and then you have the computer console. So this has got the dynamic matrix algorithm, which increases the resolution from around 0.2 millimeters to 0.02 millimeters. It has also got the optimized flying spot technique, the fractional ablation, thereby decreasing the thermal impact. So this is the first stage. The first thing is focusing of fixation as well as a line light, and then looking at the pupil centration followed by visual axis alignment, and then the laser delivery is done via the foot pedal and the touchscreen panel. So this video was shot with the help of a volunteer. You can see that the volunteer is walking into the Sedeo room, and following this, topical anesthesia is placed and then a speculum is placed. So this is similar to any slit lamp examination where you can see the chin is then kept on the chin rest of the slit lamp, and then a headband is applied to make sure that there is no movement of the head. The green light that you see there is a pupillary bisecting light. So manually with the X and Y coordinators, we place the green light, and then the visual axis alignment is done, and then the laser is delivered with the help of a foot pedal. So once this is done, the flap is then, the strap is then removed, and then the speculum is also removed. One thing which is not included in the video is the setup also comes with a reclination chair so that we can place MMC and followed by a bandage contact lens. So here you can see a live video of a patient who's undergoing surface ablation in sitting position. Patient was actually a case of Barman's dystrophy, and he's undergoing PTK of around 250 microns. You can see that there is good fixation as well as a flying spot laser. So coming on to the results of trans-PRK, our study included around 40 eyes, out of which 26 eyes had primary refractive error and 14 eyes were post-cataract surgery, residual refractive error. So all types of refractive error were included, the most common being simple myopia, and we also included up to compound myopic astigmatism as well as compound hypermetropic myopic astigmatism. The spherical powers corrected range from minus 5.5 sphere to around plus 2.25 sphere. And as far as cylindrical power is concerned, we corrected, the highest power corrected was minus 3.5 cylinder and plus 2.25 cylinder. So this is a pentacam. You can see the preoperative picture on the right and the postoperative picture on the left, showing a good central ablation indicating a myopic ablation. This is another post-cataract surgery residual refractive error patient who underwent hyperopic ablation. You can see the uniform central steepening and the peripheral flattening. On comparing the preoperative 1 month and 6 months visual acuity as shown here on logMAR, there was a significant improvement in visual acuity with a significant p-value as seen on Friedman test. Coming on to trans-PTK, 6 eyes underwent trans-PTK. You can see that majority of the patients had diagnosis of either Barman's as well as stromal dystrophy. So this is one such patient who had a combination of Rees-Buckler and a stromal dystrophy. Preoperatively, you can see the ASOCT on the left, which is showing hyperreflective areas extending to a depth of around 250 microns. So the patient underwent trans-PTK for around 250 microns. At 1 week post-op, vision improvement was 612, and at 6 months post-op, vision improved to 69. So this is yet another patient who had a combination of Barman's and stromal dystrophy. So this patient had a much, you can see the hyperreflectivity is extending greater than 250 microns. So the patient underwent ablation of around 260 microns, and 6 month post-op vision improved to 6.9. So visual acuity here in all these trans PTK patients as well improved significantly from baseline to 6 months with a significant p-value. So reepithelialization was completed in all patients by day 7 when the bandage contact lens was removed. There was significant improvement in visual acuity noted in all the eyes at 1 month post-op, with greater than 98% of eyes treated within the target diffraction of plus or minus 0.5 diopters. No adverse events were noted. Now coming on to discussion, the recent thing has been even with lenticular procedures or LASIK, we know that there is a possible cause of residual refraction in residual astigmatism in refractive surgery could be because of cyclotorsion. A lot of RVO studies are coming up with showing that there is a cyclotorsion patients in upright versus supine position undergoing laser vision correction. So we know a lot of Schwind MRS laser platform has come up with a static cyclotorsion compensation. However, this cannot be affordable by all the institutes. So coming on to Sedeo, so Sedeo, because it is going to be in upright seated position, it is going to be cyclotorsion free. It has a compact workstation. It is safe and accurate. It is less time consuming. It is going to be patient friendly because all these patients are myopes and they are used to having slit lamp examinations right from a younger age. They're very comfortable and claustrophobia free, less complex mechanics and a large working space. And there's less environmental influence because of the shorter operation as well as the aspiration distance is less plume formation. So the Sedeo eczema laser system is thus a revolutionary, safe and effective treatment option for surface ablation procedures. Thank you.
Thank you.
Thank you. No, sir. None of them. Because it's very small. It's a very small duration, sir. So hardly a few seconds, like 15 seconds, 20 seconds, that's how it is. So no vasovagal syncope in any of the 40 patients. Majority were young patients, except for those 14 patients who had post-cataract surgery, residual refractive error. All of them were young patients. They were all very comfortable.
What antibiotic you use after the application?
Vigamox only, sir, moxifloxacin. No, ma'am. There is no control group for this because this is a first machine which has come in India, and so this was a pilot study which was done with the machine. So this is a phase 1 study which was done.
Thank you.
Thank you.